Welcome to the Advanced Methods webinars, sponsored by the Agency for Healthcare Research and Quality. Your moderator for today's program is Dr. Michael Harrison, Project Director for AHRQ's Delivery System Research Initiative. Slides for today's presentation will be available shortly in the Documents folder to the lower right of the presentation screen. An announcement will be posted in the chat field when they're available. The audio for today's webinar is available by telephone or audiocast. Audiocast quality is subject to your equipment, bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option and PIN number provided in your confirmation email. Operator assistance is available to those on the telephone by pressing #. You may send your questions or comments at any time by using the chat window located on the lower left of the presentation window. A question and answer session will follow the presentation. I will now turn the call over to your moderator. Dr. Harrison, please begin.
Thanks to all of you for joining us. This is the third in a series of 5 webinars sponsored by AHRQ's Delivery System Research Initiative, which is funded under the American Recovery and Reinvestment Act of 2009, and we're partnering with AHRQ's primary care program. Our delivery system initiative supports research and demonstrations on large-scale changes in healthcare delivery, a very pressing topic in light of the current health system reforms. And the webinars are intended to help our grantees and other researchers use the most advanced methods available to plan, conduct, and report research on delivery system improvement. I just want to mention that details on the posting of this webinar will be provided by Brianna at the end of this session. And at this point, I want to turn things over to Brianna Jackson, who's a member of our contractor team, who has some polling questions to start us off. Brianna?
Good afternoon, everyone. The first question we'd like you to answer is, how familiar are you with logic models? Please select the answer which most closely describes you. Okay, answers are still trickling in. I'm going to give everyone a couple more seconds here. Okay, I'm going to close the poll now, and everyone should be seeing those results. It looks like the majority of us are somewhat familiar with logic models. The next question we'd like you to answer is, what is your general level of experience in health services research? Please select the answer which most closely describes you. A few more seconds on this one. And the majority of us today are at the beginning level of experience in health services research. Now that we know a little bit more about our audience, Michael will introduce our speakers.
Thanks, Brianna. That's very helpful. Our first speaker today is Dana Peterson, PhD. Dana is a health researcher at Mathematical Policy Research. She received her doctorate in health services and analysis from the University of California, Berkeley, and has more than 15 years of evaluation experience, including research design, qualitative and quantitative data collection analysis. And she's implemented formative, summative, and outcome studies for a wide range of clients, including foundations, county, state, and federal governments. Dana is the lead author of the Brief on Logic Models in AHRQ's PCMH Research Methods series, and her presentation today is based on that methods brief. Dana?
Hello, everyone. Can we have the first slide? Great. So thank you, Michael, for that introduction. This presentation, as Michael said, focuses on the use of logic models in evaluations of patient-centered medical homes, which I'll refer to as medical homes throughout this conversation today. And also, as Michael said, it presents information from one brief in a series developed by AHRQ in partnership with Mathematica and other thought leaders in research methods and medical home models to expand the toolbox of methods to evaluate and refine those models. So for those of you unfamiliar with a medical home model, it's a primary care approach that aims to improve the quality, cost, patient, and provider experience. So although my presentation today is going to focus on the use of logic models in studies of the medical home, I just want to specify that the methodology is applicable to any intervention and other healthcare delivery models.
Similarly, I want to specify that although the use of logic models is a tried and true method, it is not used as much in healthcare research as it could be. So given the large number of individuals listening today, I see that some are well-versed in the use of logic models, while others have only used them sparingly. So I'm going to try to take kind of a middle road in this presentation, providing both a high-level overview as well as some specifics, hoping that each of you can find something useful. Next slide. So before we begin, I want to acknowledge David Myers and Jan Ginevro at AHRQ, who commissioned the full series of briefs and this specific brief that I'm discussing today. And I also want to acknowledge my two co-authors, Erin Taylor and Debbie Pikus, who helped to co-author the brief. The brief itself is available for download from pcmh.arc.gov. Next slide. So the outline for today. Today I'm going to talk about what is a logic model and define some of its core elements. I want to talk about its key purposes and potential users of logic models, briefly discuss how to build a logic model, then talk about its applicability to PCMH medical home models and some advantages and limitations of the model. The discussant after me will talk about some more specific applications of logic models. So what is a logic model? First, I just want to say the logic model is a picture of your intervention. It's a graphical depiction that shows the necessary resources and inputs, the intervention activities and processes, the intermediate and ultimate outcomes of the intervention, and the pathway through which those affect outcomes or are pretended to affect outcomes, the interrelationships among those components, and also the contextual factors that may influence the intervention's ability to produce results. Ultimately, it's a picture that tries to show all the links in a chain of reasoning about what causes what, illustrating the sequence of events that bring about change on a particular pathway towards outcomes. In their simplest form, logic models are a linear representation of the underlying logic behind a program or intervention, but they can vary in complexity and they take many forms, including flowcharts, tables, pictures, diagrams, and include different components, but they generally all contain some core elements. This next slide, switch slides, yep, shows some elements of a basic logic model. So generally, I should say, one reads a logic model from left to right. So in this example, on the far left of the model, you see that an intervention contains inputs, components, and outputs. Inputs are what we invest, time, money, partners, things like that. The components or outputs are related to what we do, the services and activities we provided as part of the intervention, and those things we observe if those activities and services are provided, like the number of people served or the number of trainings provided. Then moving farther to right, we see that when the intervention is delivered, we hypothesize that a set of outcomes will be obtained. These can be short, intermediate, and long-term, each leading to the next. Additionally, a good logic model identifies the contextual factors that potentially affect each part of the chain, and this is depicted at the bottom of this slide. Next slide. So logic models serve multiple purposes and are useful for planners, implementers, and evaluators. For example, logic models help facilitate understanding of complex interventions. They show at a glance what an intervention is, how it works, and what is intended to achieve. They clarify the black box of an intervention and can distill the project down to its core pieces while maintaining a focus on the interconnectedness of those pieces. This is helpful for planners, implementers, and evaluators alike. They also serve as a useful communication piece with other stakeholders. Developing a logic model collaboratively also can help planners, implementers, and evaluators to clarify goals and develop shared understanding by covering disagreement or at least varying perspectives among stakeholders about how an intervention works. Developing a logic model may also highlight where there are conceptual gaps between the components and their outputs. For example, one might assume at the start that they're getting directly from A to C, but developing a logic model helps them identify that Part B is a necessary piece of the puzzle along the way. Third, implementers can use logic models to track implementation progress and fidelity, as well as show how the intervention evolves over time. Tracking indicators for each step in the logic model process can identify emerging needs for program refinement and mid-course corrections. It may also pinpoint areas of insufficient inputs where extra resources are needed, or where TA or technical assistance really could support ongoing implementation. Fourth, for evaluators, logic models can really guide the choice and timing of measures. They provide a theory-based structure for identifying evaluable changes. Understanding the underlying logic of an intervention from its start to finish allows evaluators to select measurable indicators and to be both used in implementation and impact analyses. And then finally here, logic models provide a framework for interpreting results at the end of your study. Designing data collection to align with a logic model allows evaluators to examine and test the intervention logic that is depicted in that model, and it provides a plausible explanation for the hypothesized causal mechanisms if the desired outcomes are attained. If the outcomes are not attained, the evaluation, if it's firmly based on the logic model, can help reveal which links in that chain of logic were broken. So this next slide shows, hold on a second here. This next slide shows some basic ideas about how to build a logic model. So first, I just want to say there's no single or right way to do that. It depends on an individual's purpose and their preferences. For example, some people start with the problem that they're trying to solve, and they build the model by working toward the outcomes. That is, they develop the model moving left to right. Others start with the desired outcomes and work backwards, trying to figure out what's needed to get there, moving right to left. Logic models can be designed by a single person, but are often more accurate if vetted and revised with others, collaboratively developing a shared understanding and fleshing out what's really going on. But no matter how you go about it, it's important when building a logic model to kind of answer 5 basic questions that are listed here. What's the problem you're trying to solve? What outcomes would represent success? What are you really doing to achieve those outcomes? What are inputs and resources that are needed? And what contextual factors are kind of affecting what you're doing all along the way? Once you've answered those questions, you try to graphically illustrate the answer in those relationships. Next slide. As I said, logic models can be used when studying any intervention, but they are particularly useful in studies of multifaceted interventions like medical homes. And we consider medical homes to be multifaceted because they often consist of multiple and interrelated components. They are often intended to affect change on multiple levels. This could be for patients in terms of the quality of care they receive. It could be for providers on the way they provide services. It could be for practices in terms of changing the way they have their medical records. And it could be for entire health systems. They also include synergies and iterative feedback loops based on a continuous quality improvement framework, so they are dynamic. And they're being tested in complex healthcare systems or contexts. So using logic models helps to overcome these challenges because they really help strengthen studies like outcome studies that often focus on effects by setting up this framework that allows you to examine all the interconnected and complex factors on that pathway toward the effects. They flush out that black box of the multifaceted intervention in the causal chain between the intervention and the observed outcomes. This next slide here shows you an example. So recognizing, as I said, that medical homes are complex and that they can vary in their components and offer more complex in reality than a logic model convey, this is an example of an overarching logic model for a medical home intervention. As shown, I'm going to read through this one from left to right. So as shown, intervention depends on a variety of inputs, including funding, staff, time, training, and technical assistance. In this example, in the intervention column here, we use AHRQ's definition of a medical home to specify an intervention that is comprehensive, patient-centered, coordinated, and accessible, and that also provides safe and high-quality care. It's true, though, that a medical home intervention may operationalize these components in different ways, and that these approaches may be further adapted to each practice's unique context. This is an overarching model. So the next box here shows example activities related to the 5 intervention components. For example, activities related to accessible services could include developing new modes of patient communication, offering translation services, expanding office hours, or offering after-hours assistance. If the activities in this column are implemented, they are intended to lead to a set of various outputs and short-term outcomes like depicted here, such as more same-day appointments or shorter wait times. And then moving even farther to the right, the intervention is hypothesized to affect the 3-part aim: quality, cost, and patient's experience, as well as improve provider experience. Note, however, that a medical home intervention may tailor efforts to focus more directly on one of these or on even a different outcome. Additionally, this model shows at the bottom that there are multiple contextual and external factors related to the specific practice environments or the overall healthcare environment that could affect both the implementation or its ability to achieve outcomes. So often for complex and multifaceted interventions like this one, it might seem overwhelming or even impossible to fully specify all these key linkages and components. So this next slide it shows an example of a more specific model. In these complex cases, given that an evaluator will want to use a logic model to guide data collection, that is what to measure and when to measure it, it may make sense to develop one overarching logic model that explains the high-level picture to stakeholders, like the one I just showed, as well as a series of more specific models for each component of a larger intervention that you want to test or examine. These specific logical models can show additional detail and may provide a better guide when developing and tracking measures. So this slide here shows an example of a logic model that more fully articulates one of the previous models' approaches to improving access, that of developing new modes of patient communication. So we see here that in this example, like the overarching model, that this strategy still requires inputs. It also implies that if these inputs are provided, then new modes of patient communication can be implemented, including 3 activities: developing a new email system, reaching out to patients about that system, and monitoring and responding to those emails. The model also shows then that if these activities are implemented as planned, we hypothesize a set of outputs. The evaluation in this case would measure these outputs, such as the number of emails sent and received, the distribution of emails among providers and patients, and the time spent responding to emails. They would also track the simple, most immediate outputs, like the existence of the email system at all, word outreach materials developed. Moving farther to the right, the evaluation would also include measures of the short and long-term outcomes shown, including quantitative measures like tracking the number of in-person visits over time, and qualitative measures like interviews with providers about their satisfaction with the new email system and changes in the quality, content, or intensity of the in-person visits they have, or focus groups with patients about their awareness, use, and satisfaction with the new email system. In sum, the evaluation would include measures that allow testing of the logic, linking the inputs to the intervention and the intervention to the desired outcomes, taking contextual factors into account. Next slide, please. Now that I've shown you some specific examples of logic models and discussed their general purposes and uses, I'd like to share some kind of the global advantages of using versus not using logic models. There are likely more than 4, but here I'll just discuss the 4 main ones. First, in the absence of a logic model, evaluators may be tempted to design data collection systems that focus largely, if not solely, on outcomes, neglecting the importance of implementation analyses that measure the processes and intermediate outcomes needed to achieve these outcomes, or they may not fully account for the inputs required or the context in which the intervention takes place. Second, logic models help guide systematic approaches to evaluation that balance the need to limit data collection efforts for efficiency's sake, yet capture the complexity of the intervention tested. By default, drafting a logic model requires one to distill the project down to its core pieces and to focus measurement there. Third, logic models, or a series of logic models as shown here, can depict the complexity of change pathways involved in complex interventions, and they thus emphasize the importance of adopting a systems approach that captures details about how each component is implemented, as well as how the components interact with each other and affect each other over time. These relationships should not be ignored when determining whether and how an intervention worked. Some medical home components may be mutually reinforcing, while others may conflict with each other in a particular context. For example, one component of the intervention may be effective, while another is not, or is less so, and without disentangling them with these models that are showing the unique pathways, you won't know which is affecting what. Finally, the use of logic models is not restricted to large-scale or rigorous impact studies. They're useful to anyone implementing or studying the implementation and outcomes of a medical home or project, including pilot projects or small practices or even case studies. Next slide. As with any methodology, logic models, though, do have some limitations. First, given that logic models, aim for this most efficient way to tell a story, rather than capturing all the detail of the intervention, they could oversimplify reality. Many interventions are very interactive and recursive and complex, so you really do need a series of logic models, and that still might not quite get at the subtle nuances of your intervention. Additionally, there's often a tension between focusing more narrowly on facets of the intervention and specifying all the internal, external, and contextual factors and things that might affect your outcomes. The challenge is to include enough depth to identify those contextual and key components of the model without losing the ability to understand the intervention as a whole. Third, some mistakenly require a logic model as static, missing the evolving nature of interventions when implemented. Delivery models change over time in response to refinements made by implementers or formative feedback or external influences. And it's important for implementers and evaluators alike to review and update logic models to ensure that they reflect innovation and current conceptualizations of the intervention they are trying to test. Fourth, logic models sometimes, if they're used too rigidly, can stifle innovative thinking or adaptive management. Interventions are not often as linear, as we've said, or straightforward as logic models portray, and it's important to remain open-minded and flexible to unanticipated dynamics or outcomes so they don't go unnoticed. If used too rigidly, an evaluation might not pick up some unintended positive outcome that could have occurred. In close, a logic model is just one of many tools needed in a strong evaluation. Alone, they don't establish causality, although they are an extremely useful and complementary tool that some evaluators overlook and are extremely useful as a complement to outcome studies. This last slide, I just wanted to present here. I wanted to tell folks, number one, where they could get a copy of the full logic model brief, and I've provided the link here. And second, I wanted to clarify that the full brief does contain a set of resources for folks that give more detailed examples on how to develop guides and some more examples of, not develop guides, develop logic models, as well as some examples of logic models for the medical home. So that's it for today. I know we're going to have Q&A at the end. Turn over the discussion now to Todd Gilmer.
Well, actually, before Todd starts, just let me thank you, Dana, and let me introduce Todd. Todd Gilmer, Ph.D., is a professor of health economics and chief of the Division of Health Policy in the Department of Family and Preventive Medicine at the University of California, San Diego. He received his Ph.D. in economics from the University of Washington. His research has focused in three areas: health insurance and risk adjustment, diabetes care, and mental health services research. And Todd's presentation draws on his AHRQ-funded research on full-service partnerships for housing and treating people who are homeless and mentally ill. Just let me remind you folks, please mute your phones. Right now I'm hearing a keyboard, and we heard some sirens beforehand, so please do mute. Todd, it's all yours. Thank you.
Sure. Thanks, Michael. We'll look at the first slide. So I'm going to talk a little bit about our study that's funded by AHRQ. And how we're using logic models to understand how programs are implemented. And we're focusing on programs for persons with serious mental illness who are homeless. And in a sense, the programs are providing a medical home model that's tailored to this group. So in that way, follows a bit from Dana's excellent presentation on logic models. So the next slide gives an overview of the talk. So I'm going to run through some background slides on our study. The programs themselves are fairly unique to give you kind of some context, and then talk about logic models at three different levels. And one is kind of where we began, conceptualizing the entire implementation and helping us identify where we're going to measure the program's processes and effects. And then the other two are very much a work in progress. So I'm going to narrow it down a little bit and focus on some specific processes we're trying to identify and show you how we're using kind of logic models in a bit of an iterative fashion to understand what we're finding in our data. So the next slide. The Mental Health Services Act was a large public policy natural experiment, we call them, in California. In 2004, a ballot or a proposition was approved by voters on the ballot, 63, that was signed into law as the Mental Health Services Act. And it's essentially a millionaire's tax, so a 1% tax on incomes over $1 million to fund new public mental health services. And so it was following a bit of a policy history in California and was targeted on specific types of programs in certain areas. So some were new services, some was prevention and early intervention focusing on stigma reduction, and some of it innovative programs. But a cornerstone of the funding were full service partnerships. And the next slide. And the FSPs are a type of supported housing program. So it combines supportive housing and team-based treatment for persons with serious mental illness who are homelessness or are homeless or at risk of homelessness. And in contrast to other kind of established team-based models like the assertive community treatment model that you might be familiar with, the ACT model is very process-based. It's very prescriptive on how you provide care. The FSPs were much more flexible. They had some general policy goals to be client-centered and recovery-oriented, and also to do whatever it takes to improve mental health outcomes and engage clients in treatment. So it gave a lot of flexibility in funding and implementation without a lot of specific guidance. And it ended up with a large variation in how these programs were implemented throughout the state. And so we took this as kind of another natural experiment building on the initial act as an opportunity to study this variation and see if we could identify which factors were most effective. So in doing so, we struggled a little bit on how to actually measure the full service partnership, since there wasn't a baseline or an existing gold standard. And after some searching around, we settled on the Housing First model. So the Housing First model was developed in New York and is very complementary to the full service partnership model. They're both supportive housing and team-based treatment models. The Housing First in New York tends to emphasize immediate placement and scattered site housing. So really focusing on apartments that are distributed throughout a city or a county. And it also focuses on client choice, which is very much related to the recovery orientation of models. And they also conveniently have a fidelity scale that measures programs in multiple domains. So we thought it'd be a very good starting point. And combined, it gave us a very useful framework. So looking at the FSPs as this natural experiment with variation in the implementation of supported housing, we used the Housing First Fidelity Scale to both map practices and give us a measure of the variation. We could then use that to see what are determinants of variation in implementation. So something that's important for this program, as well as for health services programs in general, trying to figure out what affects implementation. It also allows us to identify best practices of the FSPs, being able to compare those that are high and low fidelity on the Housing First scale, as well as to investigate what are the important components of Housing First. As Housing First itself has been a bit of a black box, they have kind of a fidelity standard, but it isn't clear which aspects of that are most important. So we're using it to address this issue in a few different ways. So the next slide shows the logic model we developed to help us kind of conceptualize the study. And we built on an existing model. So Ron Anderson has a well-known model of health services use that focuses on predisposing variables, enabling variables, need variables, and these all feed into engagement and retention and treatment, and eventually health services utilization and cost. Lillian Gilbert modified Ron's model for homeless populations, and so we used a modified version of this model to help understand full service partnerships. So you can see we've added a couple boxes on the bottom, one for full service partnership and one for fidelity of Housing First. And so kind of below the need variables, where we identify persons with severe mental illness or risk for homelessness, are what qualify you for the full service partnership. And the full service partnership then provides access to housing. They've got subsidized housing, team-based services. Treatment teams usually consist of psychiatrists and psychologists, housing specialists, employment specialists, social workers, and they also help secure financial support, SSI and Medicaid typically, and also provide employment and vocational support. And so this kind of comprehensive model then feeds both ways. It addresses some of the vulnerabilities among this client population, specifically housing and financial support, competing needs and personal safety, and also improves engagement, retention, and treatment. And then we believe that engagement would be modified by Fidelity. So the main, some of the main aspects of Fidelity are consumer choice, to what extent consumers can choose their housing, choose the treatment that they're going to participate in, how there's a separation of between housing and treatment. You're not required to participate in treatment to receive housing, and the array of services available. And so we thought more Fidelity programs might be more effective at engaging patients in outpatient care and would improve housing retention. So that helps us identify our hypotheses and how we would set up our analysis. And some of our final outcomes then, we're looking at use of outpatient mental health services, inpatient and emergency services, and costs. And so kind of as we go through, we're going to be thinking about this model with the goal in the end to update it. And we won't quite get there to the full model. But this describes the structure of our study. It's mixed methods. We have quantitative data from administrative data sources, Medicaid data systems, mental health data systems, assessment systems that model the housing of clients. And we're doing it in a propensity score matched control group framework. So we're looking at this pre-post with a control group to account for time trends. We measured fidelity to housing first in two ways. In one way, through a survey. We developed a survey that's based on the Housing First scale, and we were able to survey 94 FSP programs. That was nice because it gave us data on a broad array of programs. And we also supplemented this with site visits. So we have 20 site visits where we spent a day interviewing staff and observing the program. And that gave us some very rich qualitative data on a subset of the sites. And we're using these, combining these in various ways to help understand how the programs were implemented and the implications. So a couple of slides on kind of our intermediate results. The survey revealed that we had a two-factor model of fidelity, that there's one factor relating to the approach to housing, the extent to which scatter site housing is used versus congregate housing and having everyone live in, say, the same apartment building, to what extent housing services are separated, and the service philosophy of the program. Is this a recovery-oriented client choice program, or is it more of a prescriptive medical model program? And then a different dimension related to the service array and team structure. So basically the set of services that are available and to what extent and how effectively the group works as a team. The next slide talks about some findings from the qualitative analysis. So we did a standard, rigorous qualitative analysis based on grounded theory. And then we ended up focusing this around implementation frameworks. And in our first work on this data, identified three main areas that affected fidelity. So one is individual characteristics, including program director knowledge and beliefs of the intervention, and then characteristics of the inner setting and the outer setting of these programs. So the next slide shows how we've tried to pull some of these together. So this is our second example of logic model, and one where we're currently using to kind of work through and help organize our thoughts. So on the left-hand side are the implementation domains we identified for the qualitative analysis, and the right-hand side are the fidelity domains that we identified from the quantitative survey. And so they meet in the middle somewhere. So there's these factors that are driving fidelity of implementation. And as a result, we've got a lot of variation of fidelity on these two domains. We don't know quite yet what's happening in the middle and how this gets translated. And we're trying to figure this out using additional deeper analysis of the qualitative data, looking at more staff interviews and more programs, and merging that with the quantitative data. The next slide kind of shows you, I think, where we are in this process and how I feel often about a lot of my research. Certainly the South Park slide that's most relevant to health services research, I think the theme of this, that there was these gnomes that collected underwear for profit, and when challenged on their business plan, had this PowerPoint presentation where they said phase 1, collect underpants, phase 2, question marks, and phase 3, profit. So I think kind of right now we're trying to struggle with phase 2 to see how the variation in implementation factors relates to the observed fidelity we see, and then how that relates to outcomes. So the next slide kind of gets into, I think, something that's a little bit more targeted that is going to help us convey some of our results to policymakers. So one thing we're very much finding is that there's differences in the target populations among these programs, and that higher fidelity programs seem to be targeting sicker individuals. And so certainly these programs are set up to treat the most severely ill, but there's a lot of variation and discretion in how clients are recruited. So it may be that people are sought out in parks or living under bridges and shelters, or they may be referred from mental health outpatient programs or inpatient settings. And certainly certain clients are more challenging to engage than others. And it seems that the highest fidelity programs seek out and engage those most challenging individuals. So, and seem to have better improvements in outcomes. And so there's both this indirect effect where fidelity, high fidelity programs seem to be targeting sicker populations that's related to client outcomes, and then a total effect from fidelity to outcomes. And I'll show you this in a couple of slides here. One, two of the main outcomes, we're looking at changes in days homeless and inpatient service use. And this shows you two different analyses of changes in days homeless. And so in both of these, we see fairly large reductions in days homeless over a year. But in the left-hand graph, there's a much larger gradient by fidelity. And certainly in the lowest fidelity programs, you see virtually no improvement, and increasing improvements as you increase fidelity. And the second slide adjusts for days homeless in the pre-period. I'm sorry, can you remain on that slide? The second side of that slide looks at changes adjusting for days homeless in the pre-period. So this adjusts for the target population effect. And here there's still some improvements with fidelity, but they're much smaller. So we're hoping to use the previous figure to help explain this to policymakers. The part of the success of these high fidelity programs is they're targeting the sicker population. And then the last slide does something analogous for inpatient costs and outpatient costs. And so on the left-hand side, these estimates are stratified by the likelihood that you'll enroll in an FSP. So it's based on diagnostic severity, use of inpatient emergency services in the pre-period, so very highly correlated with illness burden. And we see it's among those programs that target the most severely ill that see the largest improvements in inpatient costs. On contrast, on the right-hand side, it shows you that outpatient costs are pretty consistent across ranges of fidelity. And so it doesn't really matter how sick you are. When you're provided this strong array of services, your service use increases quite considerably, but it's those that had the most severe service use and illness profiles in the pre-period that seem to benefit from reductions in inpatient stays. And so, kind of, I'd say in conclusions that the logic models have been very useful for us in helping us conceptualize both our study initially and helping think through the integration of the qualitative and the quantitative data. And we expect that they will also help us in conveying some of our information to policymakers and kind of explain, some of the complexity of showing, health services data regressions and standardized estimates in a way that's more accessible to people that aren't as highly trained in that area.
So thanks very much, Todd. We now have opportunities for Q&A, and Monique, have you got questions coming in? I'm not seeing them over here. Or Brianna, have you got them?
No. There are currently no questions in the...
Thus far, we haven't got questions coming in. I would encourage those of you who have questions for either speaker or both to take this opportunity to use the chat mode to raise questions, and I have a couple to kick us off. One sort of picks up where Todd left off, and that is, Dana, you mentioned this also, that logic models are useful in communicating findings to people who are not professional researchers. And Todd has given an example of this that I, as not a mental health professional, am having a little difficulty understanding if I make believe that I were a policymaker. It seems to me, if I understood you correctly, Todd, what your finding shows is that the high-fidelity programs, the ones that are following the New York model better, are targeting the sicker patients, and as a result, they're getting bigger, they're showing bigger improvements. Am I right about that?
Yeah, that's right.
Now, is that, from a policymaker standpoint, is that a good thing or a bad thing? I think it's a good thing, isn't it?
Yeah, I mean, it is a good thing what the high fidelity programs are doing. I guess it raises a question on how you encourage that among the other programs. Currently there isn't any type of financial incentive or review of these programs to kind of encourage or enforce certain types of targeting, but you could imagine developing different incentive schemes to encourage programs to go after people that are more severely ill.
Okay, great. Now, Monique, do we have any questions yet? Then I'm going to continue on this line with a question to Dana, and that is, Dana, could you give us an example from your experience where providing non-researcher audiences, either in writing or in an oral presentation, with a model really helped sort of nail what it was you were talking about and help them see it in a way they couldn't see it otherwise?
Yeah, thanks. That's a good question. Logic models I find to be kind of the basis of almost everything we do. And I was, in thinking through that question, I work currently on a very large evaluation of CHIPRA quality improvement grants, demonstration grantees at state levels, and some of those states are implementing medical home transformation efforts. And as part of that evaluation, we have qualitative data collection, we have quantitative data collection, and we have site visits. And a portion of those site visits is to providers who are working in these practices that are attempting to undergo transformation. And what's often useful in those interviews and discussions with providers about their experiences of what they're doing is to share with them a one-page picture at the beginning of that interview of this is what we understood that you're doing. This is how we think what you're doing is. And it allows them to kind of look at that and kind of disagree and agree with the various components and really get specific right away. It shortcuts the whole introduction to what we're talking about and brings things right down into reality. So it's a use for a research purpose, but it's with the implementing providers that we often use them. Is that a good example?
Yeah, that's terrific. Thank you. And I'm looking now at a number of questions that have come in. Knowing me, I've got lots more. But before I raise any more on my own, I want to turn to questions that came from our participants in the audience. Erica P. writes, for the first speaker, Dana, when a program is complex with many moving parts, what are some of the approaches for deciding which parts to do a deep dive logic model of?
That's a great question. In the case of an external evaluator, which I often am, that question is answered through dialogue with your funder or through the person who is implementing the project. So it's like, the first step is always to really understand what all the pieces are, and then it's through this iterative conversation. Where do you think your intervention is going to have the biggest biggest bang, or impact on outcomes? That might be one of the components you want to develop the more specific model if that's your primary interest. If your primary interest is there's this thing going on that we don't fully understand, that might be another area to try to more fully tease out the logic model. So as I said, there are multiple ways to develop a logic model. It really depends on the context about which area you would blow up into a more specific model.
I think that's very, very helpful. And I've got a question here from Sandy C. that was actually one of the ones on my list as well. I think it could go either to Dana or Todd. Sandy C. writes, could you speak to how you've revisited your initial logic models mid-course and modify them as appropriate based on what you're learning? And I would simply add to that, the modification might also occur because the program itself changes. And I'm going to add another question, and that is, could you give the folks an example of something they could access where they could actually see this attempt to sort of try to show the logic at time 1, time 2, and possibly time 3? So we can start with Dana and then go over to Todd if you have thoughts as well, Todd. Dana?
Sure. So in terms of revisiting and modifying logic models, I think as a general course, one should revisit and relook at their logic model at least once a year regardless, even if you don't think anything might have changed, just to make sure it's still flowing with what all of your stakeholders believe is going on. It just generates a useful kind of process check-in. I think the question wasn't necessarily about when, but why also, Michael, is that right? Why you might revisit? Michael?
I'm sorry, I was on mute.
That's okay.
Took me a second to unmute. I think the question was primarily, let's see, let me go back to it here.
Sorry.
It's okay. I think the question was primarily about how you would show that, but let me just see here. Have you revisited your initial logic, and based on what, could you speak to how you have revised?
Okay.
The actual revision process, yeah.
Okay, so it's through an iterative discussion with your stakeholders could be one way, or if you are, for example, documenting, you have measures for the various pieces of your model that you're implementing, you're tracking over time, and you might see that one piece of your model, you thought that implementing trainings for physicians was going to require X resources, and that was in your model. But in the course of doing this for 1 year, you realize that what you have identified in your model as sufficient resources were entirely insufficient. I might revisit my model and modify it to include the additional resources that were necessary, or add an additional component for technical assistance. On the other side of the model, if we're moving over to the right, I might have not included an intended or anticipated outcome around increased patient satisfaction, when that might occur as an unexpected outcome that I want to continue tracking once I notice it the first time, and I might explicitly add that to my model. So those are the types of changes that would happen. Or, ACA, for example, that's a contextual factor that logic models across the country were revised to include, and all the things that were changed in terms of contextual factors and in their influences on interventions. So there are all kinds of changes that happen that need these revisions. In terms of an example, I will have to think about that. I can't off the top of my head think of any published examples of modified logic models that I could refer someone to, but I often I might be able to find some reports where we've included them kind of in our implementation phase. We have, right, and we show those changes.
Okay, that'd be terrific if you did. And before I turn to Todd, I'll just mention one other possibility, and that is unintended consequences are by definition things that you didn't have in your model when you started. And when one starts to come on them, one may want to then put them into your intermediate or even ultimate outcomes. Todd, do you have thoughts on this question, which was about how you go about modifying your model?
Sure, and I think kind of in our, my example is all about that. Although I'm not exactly showing the updates of the model, we had kind of this idea of fidelity affecting outcomes, but fidelity itself, we displayed as kind of a box, a black box. And what we're trying to do in our study is to peer into that box a bit and hopefully explain it in a more detailed fashion. So I imagine that at the end of our study, we could develop a new logic model, something to build the next study on, that would provide more detail on fidelity and how it would feed back and forth between the population being served and the outcomes we're seeing. And kind of to relate to the previous question a little bit, is that in doing that, some of it depends on what emerges from the data. So we certainly did go in with a construct of fidelity and what we thought it would look like as we kind of look through the qualitative data and the quantitative data. Certainly certain aspects are emerging as important that it was hard to know beforehand that those exactly would be the areas we're highlighting. And so some of it will depend on your specific research application and what appears to be important and what drives your kind of scientific curiosity.
Okay, thanks, Todd. That's very helpful. I've got another question here, and I want to encourage folks, if you have other questions, do send them in. Before I turn to that last question, just a request, and that is, if either of you, Dana, perhaps you may want to comment before Todd, or only, have come on a source to which people could turn for advice and rules of thumb about constructing graphic models of logic models or other kinds of graphic models. Could you recommend it? One of the things that I've discovered in my own work is that a lot of it's intuitive, and yet there are people who have actually tried to lay out some of the rules of thumb the same way they've laid out rules of thumb about PowerPoints, don't put more than 6 bullets on a PowerPoint, and, use parallel structure and that kind of stuff. I mean, a lot of these things are intuitive, but sometimes you can find either a web source or some other source that says, here's some helpful hints on how to do graphics. Do either of you have any suggestions in that department?
This is Dana. In terms of the specific graphics of it, I don't think I can think of anything right off the top of my head that's just about that piece, but there are a number of really useful guides that discuss the whole process of how you kind of work through what it is you want to do graphically and then how to put it together in the full brief that I left the citation for on the last slide in my presentation, and those might be really helpful to people. I do find, however, that the how-to guides generally take the more linear approach, which I don't think is always the most appropriate for people's interventions. You saw in Todd's examples that really the logic of your intervention could be diagrammed in many different ways. So I'm not sure I have the perfect answer for you, Michael. Todd?
I don't. I think the references you provided are great. And when it gets down to actually having these appear on the screen in a way that looks fairly attractive, I'm certainly challenged in that regard.
Okay, yeah, it's a challenge for all of us, and my experience is just sort of do it, show it to somebody. If it doesn't make sense, do it again. It's kind of an iterative process, and for those of you who have not done it, I just want to comfort you. It's extremely time-consuming, even for folks who've done it more than once. It's one of the hard things to do and get right. Here's a question from Hesborn W. In the first presentation, that would be Dana's, it was mentioned that logic models can be complemented by other tools. Could you provide examples of such tools?
Oh, sure. I think Todd's presentation provided an excellent example of that. So when they say they can be complemented by other tools, I mean that they establish a framework, if you will, for what you want to measure and when you want to measure it. But the other tools could be surveys, could be site visits, could be document review, could be interviews. There are other data collection methodologies that help you collect the information to document whether or not the things you think are happening are actually happening. So that's what I meant by other tools.
Okay, great. The other thing I would mention is that the site that Dana provided, and we will provide you again at the end of this presentation, lists 10 briefs on advanced methods, and I think you will find that all 10 of them have really terrific material in them, and that all 10 of them also have references to other materials. So it's really a very valuable resource that our colleagues in the primary care program created, and we're really delighted to take advantage of it and help share parts of it. But we're only having 4 sessions, dealing with 4 out of the 10 briefs, and there's a lot more there. So I would certainly encourage you to take a look there. I'm just going to pause for a moment to see if I've got any more. Yes, here's a question. How much time should you budget to develop a model? Another toughie. Either of you want to comment on that?
I'm going to let Todd go first on this one.
Well, we spent a long time developing our first conceptual model, and in part it's because you're really developing an entire theory or approach to logic underlying what you're working on, and so but we also had kind of the benefit of building on an existing health services model. So I guess if you're kind of new to this, I would suggest first looking around for people that have done something fairly similar. And certainly Dana's work, if you're looking at the primary care medical home or in other areas to help either to build on something or to kind of help you start formulating your thoughts on what it might look like. But it's kind of having that logic is the result of a lot of thought and literature review and kind of pulling those things together. So unfortunately, I can't think of a good rule of thumb because it'll depend, I imagine, quite a bit on your familiarity with the topic and the area.
Right. I'll just mention something from the perspective of somebody who's been on both sides of the review process, which is, say, both submitting and then on the other side of reviewing or working with people who are reviewing, and that is solicitations very often call for the inclusion of a logic model. And I would say that this is one of the areas where it really pays to invest, because what you have to recognize is that your reviewers are very busy people. They may be looking at a large number of documents, and these documents sometimes are very, very long, depending on what the parameters are that are specified by the agency, but they can run anywhere from 25 to 50 or 100 pages. And a logic model is going to be taken as the picture that's worth 1,000 words, and if it's only worth 999, there's a problem, okay? You want it to be worth that 1,000, because that's the thing that people are going to take away from that lengthy document as the core of the intervention and the pieces of the intervention that are going to be studied, let us say, for example. So it's well worth investing if that's the goal that you're using the model for. There's a technical question here from an individual by the name of Handao. Are the models constructed in Word, or are there specialized software packages around for constructing them? Anybody on that one? Dana?
I don't know of any specific software packages. The ones I presented were constructed in PowerPoint. I think Todd's were done in Word. I often just create them in Word. So I think either of those are useful. I've also used logic models that were in form of simple tables. I mean, it doesn't have to be as complex with arrows and interconnecting dots.
Right. Regrettably, now we're running up against our time deadline. First of all, I just want to thank both of you for your presentations and all of you for taking part, and I want to turn the forum back over to Brianna. Brianna?
This concludes today's Advanced Methods webinar on logic models. If you hadn't had the chance to register for other events in our series, please do so now by following the link on your screen. This link will also be sent out to all webinar participants in a follow-up email along with a link to the recording of this presentation. For more information about the AHRQ PCMH research methods briefs on which these presentations have been based, please go to www.pcmh.ahrq.gov and visit the Evidence and Evaluation page or follow the link on your screen. Thank you for attending. Have a nice day.